Okay, great. Well, thank you all so much for being here this afternoon. Today we are joined by Dr. Talya Miron-Shatz and Dr. Angie Fagerlin to talk about Dr. Miron-Shatz's new book, Your Life Depends on It, What You Can Do to Make Better Choices About Your Health. Dr. Talya Miron-Shatz is a keynote speaker, consultant, and researcher at the intersection of medicine and behavioral economics, and the author of the recently published Your Life Depends on It. She is a visiting researcher at the University of Cambridge. Dr. Miron-Shatz was Nobel Prize winner Daniel Kahneman's postdoc at Princeton University and a lecturer at Wharton, the University of Pennsylvania. She's published over 60 academic papers on medical decision-making. She is CEO of CureMyWay, an international health consulting firm whose clients include Johnson & Johnson, Pfizer, and Samsung. Dr. Angie Fagerlin is a professor and chair in the Department of Population Health Sciences at University of Utah Health and a research scientist at the Salt Lake City VA. Her training is in experimental psychology, primarily in the areas of cognitive and social psychology. Her research focuses on testing methods for communicating medical data to patients and providers, and the development and testing of decision support interventions. Fagerlin's recent work is testing the impact of patient decision aids on patient-physician communication. Additionally, she is testing multiple methods for communicating about genetic testing and infectious diseases. Her research has been funded by VA, NCI, NIH, and the European Union. And before I turn the time over to the two of them, I just wanted to briefly touch on a couple of the upcoming events at our bookstore. Tonight at 6 p.m. is our virtual Lit Knit, which is held over Zoom. It's open to crafters of any kind, and it's always a lot of fun. And if you'd like to attend, you can email Catherine with a C at wellerbookworks.com for the Zoom link. Tomorrow night at 6 p.m. on this very YouTube channel, we'll be hosting Elena Dillon to talk about her memoir, My Body is a Big Fat Temple, which details her experience with first-time pregnancy and being a mom. We'll be ending today's discussion with a 10 to 15-minute Q&A. So if you have any questions for either of these lovely doctors, drop them in the YouTube chat box and I'll make sure they get asked. And finally, if you enjoy this conversation, please consider supporting Dr. Miron-Shatz by buying her book, and please consider supporting our bookstore by buying it through us. And I'll leave links where you can do so down below. And without further ado, I'd like to turn the time over to Talya and Angie. Thank you both so much for being here.
Salem, thank you for having us.
Thank you. I appreciate the opportunity to talk with Dr. Miron-Shatz about her work and all the great tips she has in her book and thoughts about how to improve healthcare for patients. So let me just start off by asking you a quick question. It's a pretty broad question, but when you were trying to decide to write this book and you wrote it, what were you trying to accomplish by writing the book? You know, what needs were you trying to meet? Who are you trying to help? Who are you trying to reach? What inspired you to write this phenomenal book?
You asked 30 wonderful questions. I'll try to answer, and please cut me off at any point so I don't feel like I'm addressing the nation. I went into medical decision making a long time ago when I was a graduate student and I was teaching it. I was asked to teach it. It was sort of a gig, which is funny because it became my life. But it started as a gig teaching genetic counseling students. And that meant I had to read a lot about medical decision making. That also meant I said, wait a minute, can I sit in on a consultation? Because I had 3 kids at the time, but I never had genetic counseling. And I sat in on a session, and that was amazing. And you may have had similar experiences, or anyone in the audience. There was a wonderful professional, a genetic counselor, explaining a lot of things to a couple. They were pregnant, and they had a little girl with them. They could also not hear very well, so they had a translator with them in a tiny little room full of chromosomes and genes and confusion. And it was such a discrepancy between the professional and the patients, and just the confusion and the miscommunication. And I think it hijacked me. It took over my life. So I went to Princeton and I worked on happiness. But then I thought, like, no offense to happiness. Happiness is great.
We love happiness.
We do. We're happy to be happy. But I thought, oh, well, you should do something like one day you're going to go up to heaven and God's going to ask, what were you doing exactly with your time? I should have a good answer. And I thought medical decision making was a better answer. So that's how I became involved in this domain that, you really are a much bigger expert than me.
Well, thank you. That's kind. Not sure about that, but that's kind.
I am. I was writing academic papers. That's what we do. And my daughter, it's her fault. She kept saying, Mom, nobody reads your papers. And I'm like, that's not true. People read my papers. They do. But the truth is that I wrote a lot of papers and I had a lot of interesting findings, etc. But if you want to make a difference, I think it's hard. It's when you're an academic and you're passionate about research, that's great. When you're an academic and you're passionate about research, but also passionate about making a change in the world, you have to do something beyond research. And I thought the something beyond research would be writing a book. Here it is, by the way. Voila.
It doesn't work with my filter. There we go.
Amazing. Yours doesn't show. Oh, yeah. It just shows for a second.
Yeah, because I have my filter on, so you don't see my kids' artwork behind me.
Well, we see University of Utah. That's great patriotism. That's, go.
Go. And who? So, and I appreciate what you said about the genetic counselor, because I was an old mom and I saw the genetic counselor quite a bit. And I remember from that experience how, even as somebody who studies numeracy, who studies the understanding of numbers, who has been studying for decision making for now over 2 decades, that even that was hard for me because of all the emotions that you feel, plus all the, just in your case, the distractions, and as well as, the numbers they're tough. You have to really understand numbers. And so that's also led to a lot of the work I've done to try to better, how do we help people be involved in the decisions versus just somebody telling them what to do, right? And go ahead.
I want to stay for a second with you.
Sorry.
What you said, so precious. What you said is precious. Now, people may not know this, but you wrote the subjective numeracy scale. It's like, what? So there's numeracy. Literacy is, can you read? It's much more than that, but let's simplify. Numeracy is, can you understand numbers? Mostly, can you understand probability? And the way it's measured is by questions like, if a lottery has a 1 in 1,000 chance, people join it have a 1 in 1,000 chance of winning, how many winners will there be in 10,000 people? So when we give this survey out to just innocent participants, sometimes they say, I already did my SATs. I don't want to do this. Seriously, these are just simple questions.
Oh, yeah. I'm not a numbers person. Back in the days, I can't balance my checkbook, right? Like, yeah.
Exactly. So what you did is you created a subjective numeracy scale, which says, do you feel comfortable with numbers? Do you use numbers, etc.? It's a way of gauging that. And that's amazing. So here we are talking to Dr. Angie Fagerlin, who created the subjective numeracy scale because she knows a thing or two about numeracy. She's sitting in genetic counseling and she says the numbers are difficult. That's phenomenal. That's phenomenal. That's just so real. And I love that because I wanted everyone reading the book to know that this confusion, this difficulty, this sense of the numbers are difficult, and they are, is not any reflection on them. It's not like, well, if only I was smarter. It's, it's who you are. And it is really, really hard. And in fact, I interviewed a lot of patients for the book. All of them were doctors. So I made a point of not, they can't say, well, the janitor didn't understand. I would understand. Well, no, Mr. Doctor, you wouldn't understand either. Really, it was super important for me. And you asked who my target audience was. So I thought in the beginning, and it takes quite a while to write a book. So in the beginning of that journey, I thought I was writing a book for patients. And I was, and I hope patients read it because I think it's very helpful. But then I realized, well, patients, they don't operate in a void. They talk to doctors, and doctors need to understand what are the patients going through, what's happening with them, how can we help them. So the book is also for doctors and their takeaways for patients, takeaways for doctors. Then, as I write and my thinking around this evolves, I think, what? Did you forget your master's was in organizational psychology? Like, hello, this conversation between the doctor and the patient, it doesn't take place in a void. It takes place within the confines of an organization that dictates. Do I look at you when we speak? And, do people say hello? Like, hi, what brings you here? How can I help you? Or do they just type ahead? And that's important, but also looking at us and saying, hi, and what can I do for you? And this is my name, and this is your name. We're two people here interacting in order to make your health better. That can take all of 15 seconds, but someone has to allocate these 15 seconds and someone has to say, this has got to happen. I demand that this happens. And I demand, it's not me, the patient, saying, hey, doctor, look at me. It's the medical establishment saying to the doctor, when you meet a patient, this is how you meet them. There's a meet and greet because it's a person. It's not like, here's a broken radio, fix the radio. Maybe my knee is broken and you're going to fix it. And that's very kind of you. But the knee, is connected to this person here. And so that's why I also wrote takeaways for healthcare executives, because the things we were talking about, numeracy and numbers are difficult. So you're a very smart patient, and I'm sure you go to see very capable physicians, but they're not experts in conveying numbers. They need help. They need help from someone in their organization who will say, you're going to have patients, you're going to give them probabilities about the likelihood of their pregnancy being great or being, maybe somewhat problematic. And this is how you should do this. And we're going to help you. So that became a 3-layered book, which is also very fun. It's a fun book.
It is. It's very fun. I've enjoyed it. And I loved reading the takeaways at the 3 different perspectives. And as a leader at the University of Utah, I was very excited to see you recognize what we've done to try, with exceptional patient experience, try to change that culture to improve the experiences of patients, and how, where we were when I came here 6 years ago, 7 years ago next month, is a very different place than it was before we started that journey in terms of improving those relationships between patients and their clinicians.
Right. I mean, I'm excited, actually. So for those of you who have not yet read the book, first of all, seriously, it's a must. And it's your Christmas gift to yourself, or your belated Hanukkah gift to yourself, or your whatever gift to yourself. Just don't forget. So a really beautiful case study that I describe is the University of Utah healthcare system and the way it turned itself around. But that took a long time. That took organizational commitment. It wasn't a slap on. It wasn't just, let's just do whatever. Let's buy the nurses better outfits. No. It was really very deep and very thorough. And one of the things I did throughout the book is I try to be devious. So I try to think, what do I want to happen? I want patient care to be better. I want patients to be happier and healthier, and doctors likewise, because the doctor who's not treating you well, they're not happy. You don't like them. You're not connecting with them. They're not helping you. It's a lose-lose. And then you leave the clinic and you're like, this sucked. This was not a good visit. I don't like this place. So you don't like the place. Business-wise, it's bad. So what I try to do is to say, doing good by patients, doing good by doctors is also good for business. There's a bottom line, and it's going to look good. And it did look good for the University of Utah healthcare system in terms of ratings, also in terms of revenue. So there's
and also in terms of happiness of the patients and happiness of the providers. So in all aspects, it helped everybody. Because as you said in the book, it's being able, it made the doctors happier too and enjoyed their jobs. And then obviously the patients had a better experience. And so it's been a really neat journey. I want to go back to something else. We were talking about litigion bit, and then we moved to another topic. but you're talking a lot about how this is a partnership, really, in some ways, between patients and providers. So those of us who live this jargon, we call that shared decision making, right? The idea that the decision is not made by one of the people in isolation of the other, that the doctor or the nurse practitioner, the PA, or whoever it might be, is coming into the conversation with this amazing medical knowledge, right? And they're going to come and talk with you about the disease and what your diagnosis is and the risks and the benefits. And then the patient will come in with their experiences, right? How they feel and what they're living with and their goals and their values and their preferences. And then they come together to make a decision. We call that shared decision making. It's a great concept, right? This is what we strive for, but it's tricky, right? Like how does this actually work in the real world and not in an academic paper?
So if I was smart enough, I would time how long it took you to explain shared decision making. No, seriously.
A little shorter. I could have been more concise, but
no, but it was good. I mean, it was just the right amount of words, but it's a lot of words.
Yeah.
And when someone's typing ahead and asking about one's headache and blood pressure, there's not always a ton of time for that. So there are just so many constraints. There are so many good intentions. Obviously, I mean, the patient comes in and they want to do good by their health. The doctor did not go to medical school in order to hurt patients, one would hope, right? That's like absolute torture, all these years of studying, and you do that because you're very committed and you really want to help. But then it becomes difficult. So it becomes difficult because you need to convey numbers, probabilities. You need to convey medical information in a way that the patient will understand. And if you start, I give an example in the book of this lady that goes to see the doctor, and the doctor talks to her about her creatinine level and says they're pretty high. What does she do? Smile and nod, right? Because what's creatinine? Yeah, you don't want to ask, you don't want to appear stupid. And it's like, maybe I'm not supposed to understand this. There are just so many premises. There's the premise that if I don't understand, it's my fault, or I shouldn't bother the doctor, or the doctor didn't ask me all these questions, so maybe this information is irrelevant. So there are just so many barriers. But in this example, the doctor said, it just means that you're dehydrated. And she said, oh my God, you told me to only drink 4 glasses of water a day a while ago. And he said, no, you can definitely go up to 6. And all her problems disappeared. And that's because of the shift from creatinine, which is, to water, which is, I know what water is. I know what I can do about it. Okay, so that's a huge difference. So in theory, talking about creatinine is like you've got information and it's useless. It's really useless. So that's like one caveat over there. I mean, shared decision-making is a wonderful idea, and I've been a convert for a very long time now. In fact, there's a little snippet I would like to read from the book, if that's okay.
Great. Oh, that would be fabulous. I think that would be fun to hear.
Yay. Ooh, okay. Early morning, Frankfurt, Germany. Franz Legaret, physician and advocate for shared decision-making, and I are practicing yoga on a stretch of lawn overlooking the Main River. I am filled with gratitude for having the time and ability to do yoga and for being a part of this mission. Soon we will return to the hotel where Gerd Gigerenzer, who's a very big name in risk communication, has summoned a few dozen scholars to contribute to a book envisioning better healthcare decisions. My group was discussing health literacy, that's how to understand health information that's not numeric. And I was turning conclusions into a chapter for the book. This is my milieu. These are people I look up to and whose dedication to supporting physicians and patients I admire. Some patients resent the idea that they require any support. And I'm going to open a parenthesis here and say that recently for the book launch, I wrote an article for the Wall Street Journal. And the title was, Patients May Need Help Deciding. People were livid. Some people loved it. There were hundreds of comments, letters to the editor. Some people were just so angry with me. I mean, it was like a mafia vibe. I was like, what do you mean I can't decide? Who the heck are you to tell me? I was saying, You know, some people want to decide, some people don't want to decide, and it's all good. And this is really what I wrote about here. So I'm going back to the book. So some patients resent the idea that they require any support. Sun is such a person. We met at a party Facebook threw in Palo Alto. When I told Sun what I did and how it related to shared decision making, she replied that she liked to decide on her own. She is a senior partner at an accounting firm and runs a tight ship at home with her wife and 3 boys. Her hair is always tied in a bun with no stray ends peeking out. Sun's friends seek her advice. After all, she was born in the year of the dragon, which means that she has innate leadership. She told me about her father, Jianhua, a retired tailor who was born in the year of the dog. He is honest and prudent, but not a leader. He appreciates a medical authority he can rely on when making decisions. My colleagues and I, doctors and psychologists, have long aimed to ensure that the medical system worked just as well for people like Sun as it would for people like Jianhua. Most of us thought the best way to cater to Sun and Jianhua's needs was through shared decision-making.
Thank you for reading that. And as a mother of a dog and a dragon, that resonates, and as we're a Chinese household, that whole thing resonated really, really clearly with me. I think what's interesting, and there has been discussion about, almost like sometimes people being forced to participate in decisions that they don't want. So like going to her father, and we've shown in some of the work that I've done that actually forcing people to be more involved or less involved are equally harmful to people, right? Making people take part in a decision that they're not comfortable in taking part of is harmful, but also not giving them a voice can be harmful to their experiences as a patient. And so I thought that was interesting. And I think that's what's really important in patient-provider communication is one, for the patient. As for me, I know when I go in, and it's very context specific, right? So when I had my babies, I'm also a mother of 3, as your example. I knew exactly, and you have 3 too. I knew exactly what I was going to do, if I was going to have an epidural or not, like my whole plan, right? But there's other times when I go to the doctor where it's an emergent thing, I don't have the information, that sometimes I lean more. I joke, I have 3 boys. They are as hyper as their mother. And they always would get face lacerations from falling. And I got to the point where I don't want to have a conversation with you, Dr. ER. Least scar, least pain. Those are my values. I'm covered in blood and my child is screaming. You take those values and make a decision for me based on what will cost the least amount of pain for them, in terms of stitching or gluing or stapling. And that has the best outcome. And I think that's okay too. There wasn't a sharing, there's kind of sharing, because I gave my values in 5 seconds. After the first time when I was a mess, the second to the 5th time, that all happened in like a year, I just, said it. And I think really respecting people's right to choose how involved, and asking, like, how involved do you want to be in this? Like, and kind of talking that through is a really helpful thing. And for patients to know when that it's okay to say, I have a lot of opinions and I want to speak my mind, or, hey, I'm really confused by these are words I don't know. Maybe I really want your recommendation. Can you give me a recommendation and tell me why you think it's best for me? What are your thoughts on this whole, how do we make sure decision-making happen in real, in the clinic room?
I absolutely love everything you said, other than your boys being hurt a lot. Other than that, I totally love it. And that's your fault for having 3 boys. I mean, what did you expect? But
I know, that was a plan, all boys.
I'll bet. So I absolutely love what you say, because I think with shared decision making, there really are 2 levels. And we tend to focus on the level of what are you deciding? What are you choosing? But there's also the level that precedes it, is just all encompassing of how do you want to decide? And you can say, just like you so beautifully said, I'm in the ER, I'm covered in my kid's blood, he's screaming, he's in pain, make it stop, make it painless, keep his beautiful face, and they're beautiful. I've seen your kids on Facebook, and that, I don't care which glue no, that's your job. Like, I trust you. I'm here. This is what's important to me. And I think that's wonderful, because you're stating your values. You're stating exactly how you want to decide. Your doctor is respecting that. I also think it's beautiful coming from you, because it says not everyone who's a professor, a doctor in medical decision-making always wants to be making a medical decision other than treat my boy well, please, and quick. No, really, seriously.
Yeah,
like
no,
that,
yeah. And
that's fine.
And I think a lot of people vary based on what the context is, and I think that's okay. And there's no shame in asking for help.
Absolutely.
But-
It's actually necessary. In fact, I think it's also typical of emergencies,
Right.
of situations where you say there's a pressing need. I'm not going to go home now and read about, I could, but I'm not going to, because my poor kid here needs help right now. And that's more important. And in fact, I have work on delivery, on unplanned cesarean section. Who wants an unplanned cesarean section? Absolutely no one, right? Nobody. You mentioned your birth plan. It's nobody's birth plan is to have an unplanned cesarean, by definition. And we studied birth satisfaction, and we used a very elaborate scale. It's called the Collaborate scale of, did the doctor, engage with you in a discussion, etc. It didn't work at all. What did work was a short question, because it's a short instance of, we have very little time. We're going in for an unplanned cesarean. Oftentimes it's emergency or near emergency. And our question was, every effort was made to involve me in the decision-making process. And women who responded more affirmatively to this question had higher satisfaction. And sometimes what it meant was for the doctor to come and say, Mrs. X, we have to take you in for an unplanned cesarean delivery. Is this okay? I mean, that's a joke, or lip service, or a way of involving her in the decision, even if it's, it's not. What if she says no? She's most likely, yeah, exactly. She's most likely going to say yes. But she was respected. She was approached. She received a very short explanation, which is fine, because if she wants more information, she can ask for it, but she knows the basics. And she was asked, and she can nod or say yes or whatever. But she was asked, and she was involved, and that made a difference. And that's phenomenal. And again, I'm emphasizing that because there's work on conversations with doctors, and sometimes they're recorded. And there's this work where they said, well, there could be more discussion if it fit in the routine. It's never going to fit in the routine. And they counted the minutes and the seconds of the conversation. So it can be very short, it can be very minimal, but even your interaction with the doctor, it's short, to the point, and that's it. And that's good. And, I want to make a really, really big swift here. I mean, we're jumping, and we're in Utah. And it's all good. I'm super excited. I invited all my friends to the event. Said, who wants to go to Salt Lake City without COVID testing? And join me. So here we are. So I want to jump to digital health. And I think digital health is a place where we expect to see things happen very quickly, very clearly, ideally with some emotion. And I do a lot of consulting, and I love it, because it's like, here's a mystery. It's like a project. How do you do COPD, for really old people? How do you make
define what COPD is, in case not everybody's is familiar with that disease?
Oh, sure. So I can't remember.
Chronic
pulmonary
disease, obstructive pulmonary disease.
Right. So it's people who are oftentimes attached to oxygen. They really need help breathing. And you need to monitor how well they're breathing. And just people design apps for that, or machines for that. And you have to help them, or there are fitness watches or fitness trackers, which are for completely different demographics. But in all these cases, you need to work quickly. You need to explain quickly what's happening. What do you want the person to do? Sometimes they're a patient, sometimes they're a person who will at one point in their life be a patient, probably. And it has to happen quickly. And if they want more, they should be able to drill down for more information. But if they don't want more, they should be able to receive it very quickly. And ideally with some emotion involved, with something that will trigger them emotionally, because sometimes, or oftentimes even, as patients, our emotions really matter. Like our relationship with our doctor really matters. It's funny because it also matters in our apps. When you have an app that you like, you will use it. You say, oh, it's fun. You know, it can be doing very useful things, but if it moves you emotionally, it's going to happen more. And with our doctors, we need to care. We need to feel that they care. And it's so important. It's not trivial. It's not peripheral. I saw that patients, I mean, I didn't do this study. I did other studies. I never studied HIV patients, but HIV patients, when they say my doctor knows me as a person, they're more likely to take their medication. And diabetes patients will say that when the doctor cares about them, they will take their medication. So the whole caring and emotional is a huge, huge, huge component. So we did talk about shared decision making, and I think it's a wonderful idea. And it takes so much for it to happen. And sometimes only slivers of it can happen. And along with it, there's also the emotional component, which is, it's not shared decision making, but it's who am I deciding with? I think it's crucial, because if I don't like the doctor, I don't think the doctor cares about me. And worse, if I don't trust the doctor, then this whole discussion is moot, right? The doctor is going to say something, I'm not going to trust them, I'm not going to follow up. So there are these two circles, and they meet, and they do meet. And I was really curious. I have an old mom. She has terrible vision. So we've been going to eye doctors all over the place. I'm an only child. I'm the only one who takes her to the doctors. So I got to see over the course of many years, many doctors' offices. And oftentimes they have, and it's a thing in Hebrew, especially, patients will write thank you letters that rhyme. And the doctors will frame them. It's very cute. And they always say things like, you explained everything and was ever so nice to me. You always had patience to your patients, things like that. You know, it's not as lame as I'm making it out to be. And it almost never relates to the medical aspects.
Right.
I think because
relationship.
It's all about relationship. You know why? Because if you're nice to me, I understand that you're nice to me. If you're giving me the better pill out of 3, I may not know that there are 3.
Right.
So I was curious. And in fact, I did a study on thank you letters for medical centers because I was very curious about this. I said, let's turn this obscure hobby into research. And I analyzed 100 such letters that patients sent.
Yeah.
And I saw that their patients are as likely to thank their doctor for the medical care as they are for their personality and demeanor. And the funny thing is with personality, they will say things like, the technician came or she held my hand during the mammogram. She didn't have to, but she was so nice, things like that. And with care, they'll say good care or great care. Like, it's like, they fixed my boy or whatever. That's the level. And that's fine. That's just no scar. Exactly. You're not going to say, oh, they used the better glue or whatever. The stitching was, we don't know. So both things are crucial when we visit our doctors. If there are any healthcare executives out there listening, doctors listening, it matters a lot to your patient satisfaction, to how they rate you, to how they follow up with you, and how they evaluate you. In fact, I did another consulting gig where they wanted to use a patient rate, a system where patients rate their doctors. I said, come on, are you kidding me? because you're rating them if they're nice, if the office is nice, if it's clean, if there's parking, if the staff is friendly, that's all very good. But what about the real stuff? Like, if it was a bakery, you would also ask, are the cakes any good? I don't know, like their pastries are dry, they're too sweet, like the quality of the professional service that's being given. And I looked at ratings, and oftentimes it's left out. It's just not there. I think because I'm not sure, maybe because it's hard for patients to actually gauge and to say that doctor isn't on top of the recent articles because they didn't follow the Lancet guidelines. Very, very few patients are going to say that. That's rare.
So I think those are good points. And I know we only have about 5 more minutes. And so one of the things I wanted to talk about is, so what you have all these takeaways, right? And you talk about a lot of processes, but what do you think is really important? Like, where can we move the needle and help patients get the care, get the relationships, get the involvement that they want, and whatever that might, whether it might be, somebody who wants to be super engaged, like the woman you spoke about, or versus her father who wanted to be more passive. Like, what kind of tips or advice, or what do you have from in your book that could really kind of address that for everyone who's listening?
That's a great question, and thank you. The place where I would start is with a set of questions that I created, and I call them Ask About What Matters. So what they involve is when you're offered something, a treatment or medication, to ask about the risks. What are the risks? I like starting with the risks, because if we start with the benefits, we just fall in love with the benefits. But it's good to understand what the risks are. What are the benefits? And I'll revisit the benefits in a minute. And the third question is, what are the alternatives? And that's a super important question, because we oftentimes don't ask it. We just defer to our doctors. Our doctor offers something like knee surgery, and we say, okay, when should I come? What should I do? Because if we ask about alternative, it's like we're disrespectful, or we don't trust our doctor, or we belittle our doctor. Not a good place to be. So we're not even trained to ask these questions. That's why it's risks, benefits, alternatives. Let's always ask them. I mean, in the case of knee surgery, when you ask about benefits, you can ask, how many people like me will enjoy these benefits? I mean, because we think it's going to be 100%. The truth is, it's not.
Exactly. Somebody had 5 of those.
No, I saw you smiling. I was like, this is hitting home in a weird sort of way.
Yeah, but I'm waiting for my knee replacement after I tore my ACL the 3rd time skiing down at Brighton. So I understand, and I just had this conversation with a surgeon. This very conversation.
Wow. A friend of mine had it. I'm not sure how she hurt her knee. I don't think it was skiing. And she asked about the risks. And the doctor said, you're going to have to lie down or to be relatively mobile for 6 weeks. She was like, that's not going to happen. This is not working out. Is there an alternative? And he said,
what if I don't do anything, right?
We don't even think to ask. Who says that? And with prostate cancer, that's a very valid alternative. In her case, the doctor said there is an alternative. It's physical therapy, but nobody ever finishes the course of physical therapy and then they go in for surgery. She said, you don't know me, because I'm a yogi here. This is a friend of mine. She's not a perfectionist, because perfectionist is not perfect enough to describe it. Seriously. And he signed her up for physical therapy. She shows up, boom. She asked the physical therapist, I was only given 30 sessions. How can I get more? He's like, nobody comes after the 15th. It's too difficult. And she's like, I'm going to do it. And of course she did it. And of course she recovered. She did all the hard work because she asked about the alternative and it was right for her. And that's something else that is important for me to say. So we said, ask about what matters. We said, ask about how many people like me will enjoy the benefits. Everybody, 50 out of 100, 3 out of 100, 97 out of 100. That's super important. And this takes us to the third thing I want to say to people out there who are or will at some point make a medical decision. It's your decision. My friend who's a perfectionist and who's very active, physically active, the right decision for her was physical therapy. Is it the right decision for everybody? Absolutely not. So when we ask our doctor, what would you decide? What do I know? Maybe my doctor's sport is playing bridge. Maybe they're triathlon athlete. I don't know. So it's my decision. The one thing that's very important to me, and I know it's very important to you too, is that the decision-making process is a good one. This is something where I say, I know that it can be right or wrong. Whatever you decide is yours. But the way in which you decided that the quality of information that you receive, that is crucial. Do you receive information that you can understand in words, in numbers? Are you asked about how you want to be involved in the process? And do you get that level of involvement? These things are crucial. And then you can choose, because it's your body, right? I call my book, Your Life Depends on It. And it does. It's your life and it's your body. And you have every right to choose whatever you want, unless I'm not gonna talk. No, we're not going controversial. We're just
not in the last 2 minutes. But
no.
I think, I think those are really important points. And I think understanding what's right for you is important, and trying to make the best decision possible. But I think one thing that's really important to know is you can have the most brilliant decision process, right? Yeah. You can have your spreadsheets and like your 12 items that you're considering and and do all the things and think about it, talk to people, read every journal article, and you can still have a bad outcome.
Yes.
Or you could just like flip a coin between surgery A and surgery B and have a brilliant outcome. Those things, a lot of times they're linked, right? But a lot of times they're not. And so I think, one of the things we have to be really careful of, and I know this is not at all anything you were suggesting, but just I've seen elsewhere, is that when people have bad outcomes, well, did I make the wrong decision? Maybe you didn't. It's just sometimes, things go wrong. You might have made the best decision at the time with the information you had, but things change, all sorts of things can happen. Factors you didn't know were important, all of a sudden blocked in and happened. And so I think, a lot of times by going through and making a very careful decision, it probably improve your likelihood of a good outcome, but it's not guaranteed. And I've seen people say, oh, well, she didn't make a good decision. I'm like, not necessarily. She might have made a good decision, but unfortunately had a bad outcome because sometimes bad outcomes happen under the best of circumstances.
Absolutely. So I learned this. I wrote a short scale describing what a good decision-making process looks like. And I wrote it with Dr. Glenn Elwin, who's an MD. And I learned that from him. And that's why we left out the outcome completely, because you can decide to have knee surgery and that's the best decision you can have. And it's the best surgeon, and then your knee gets infected. God forbid, it's not going to happen to you, not at all. But it could happen, and it takes me to it's, and it's good to end on that semi-happy note. It takes me to something that's part and parcel of medicine, really of life as well, and that's uncertainty. So we want things to be certain. You marry the best guy, the best day, the best place, and then it rains. Like, what the heck? It never rains, and this No, it decided to rain. What are you going to do? That's life. And that's definitely part of medicine. And, even with the COVID vaccinations, when they came out, nobody said they're going to fully protect you from everything forever. He said there's 95% protection. And I love that, because that's life. That's not full and ironclad. That's close, as good as you can, but there is still some element of uncertainty, and we have to accept that. And in fact, when someone sometimes promises you like it's going to work for sure. It never fails. That's when I get a little bit suspicious, because I think, well, really, does it always? I don't know.
Nothing's 100%, right?
There is no 100%. No. And that's something we just have to accept. I mean, we're talking about making medical decisions, and oftentimes they're not easy and they're not fun. We have to make them the best way we can. And we just wish we didn't have to, right? We just wish we could live without thinking about it and without ever encountering a medical situation, but that's probably not going to happen. So let's make them as best as we can.
Well, we're now going to open it up to audience questions. I just wanted to thank the two of you again so much for your time and what's been like a fantastic conversation so far. Very informative, very interesting, and I love the experience and perspective that you're both bringing to this conversation. I think that's really important. And that kind of leads into the first question that I have for you, for both of you. I'd love both of your perspectives on this. Due to your experiences, working in the healthcare industry for so long, working with patients in medical decision making, were you surprised by the public's reaction to the coronavirus pandemic? Specifically, like the lockdown protests, the vaccine hesitancy, the anti-masking, and why or why not was that surprising to you?
So you're starting out with the easiest question, right?
Totally, completely uncontroversial.
I hope my
I'm not trying to stir the pot or anything. I definitely don't feel like you have to answer if you don't want to. But
do you want to go first, Talya, or do you want me to?
I'm happy for you to start. I'm happy to jump on. I have a bunch of things to say, as you can imagine.
Yeah, so I actually started studying infectious disease about a decade ago about how do you communicate, and I was funded by the European Union actually, and did a bunch of studies across Europe and also within the US. And what we found is it tended to be that people had pretty strong opinions about vaccines. Mm-hmm. There weren't a ton of people in the middle that weren't unsure. And that no matter what we did, what way we talked about it, what pictures we used, how we presented numbers, the stories, we used a lot of anecdotes, and no matter what we did, it was really hard to move people. And since the first study that my colleagues and I put in the field was March 19th of 2020, so a week after the shutdown happened. And so we've been following this for the last year and a half. And so I in some ways, I'm not surprised, because our data from even like 10 years ago would have suggested this. I guess I am a little surprised at just how extreme it has been. I can understand, and I've talked to a number of anti-vaxxers over the course of my career, trying to understand what makes you. And I came from Ann Arbor, and the doctor's office that I went to was a very hippy dippy one, and about a third of patients didn't get vaccinated at that practice. It was one of the few practices that would take care of patients who didn't vax. And so I spent a lot of time talking with my physicians. And I mean, there's actually some really thoughtful discussions about people's concerns. So I was more surprised about the masks, because I don't like masking, and I fly home to Michigan every month for family caregiving, and it's a 9-hour day in a mask, and it's not a lot of fun, but it's, I was just surprised at how angry it made people to wear them. And so I think there's a lot of things that happen in the context that are totally outside of medicine. But I'm not surprised, because this is such a deeply held conviction for people, and it has been for decades, right? And so I'm not surprised that it reared up here. And then we had a lot of other things in an undercurrent that even exasperated those differences, I think, even more. Talya?
So I come at it from another perspective, just going back to the basics of decision making and how people think. So we have two ways of thinking. We have system one, which is quick and dirty. It's like grabbing a sandwich, grab. That's system one. You use a little bit of information, you use whatever you feel like, there's a lot of emotion, and that's it, right? And then there's system two, which is more elaborate. It takes on a lot more data. It requires much more effort. And I think with COVID, people responded to it. A lot of people responded to it with system one, with like, oh, it doesn't exist, or I don't know, or I'm going to die. I mean, it was probably extreme on both sides, and the information was just maybe overwhelming and a bit too much. And we also talked about uncertainty, and COVID is, one massive lesson in uncertainty. And I think that was really hard for people. That has led them perhaps to mistrust the information, to think someone's hiding things. I read just a couple of days ago in the New York Times on the new travel bans and testing requirements to enter the US. And people were saying, why are they always changing the rules? And I thought, because reality is always changing. It's constantly changing. Wouldn't it be nice if it was just the same or better? But it's not. And that's reality. And that's complicated. So it becomes too complicated. And then people, some of them, resort to say, that's just a lie, or don't believe it, or I'm going to die. I mean, there's really a lot of extremity on both sides. I want to add that I did my PhD a long time ago on the confirmation bias. And what it is that when you have a conviction, when you have a thought, you believe it. And when some silly nonsense comes to disprove it, you just ignore it, even if it's not silly nonsense at all. You just put it aside, because your beliefs are part of who you are. They're part of your identity. They're part of your value system. And this is very difficult to change. So when people are talking about freedom, and I just read some work from students, actually, some of them are from Utah, and they spoke to people from Texas, and people were talking about freedom. Freedom is a value. It's a very important value.
And we actually, one of our first studies was actually looking at how do you communicate uncertainty. And we had done this in Europe earlier, and when you admitted uncertainty, when the healthcare provider or the policymaker, it actually decreased people's trust. But then long term, we see the same thing. When things change, we don't need to wear a mask. Don't wear masks in public. It's not needed to. Everybody needs to wear a mask to keep us safe. When we have those different messages, it can be really confusing and lead to that mistrust. At the same time, this was something we've seen coronaviruses before, but COVID-19 is something completely different that we've never seen something in our lifetimes to this scale. And so we had to learn a lot. But uncertainty, I hate uncertainty. Right. And people react differently to uncertainty, one going one extreme and another going the other extreme. And I have loved ones who've gone both directions, right, in terms of how they're dealing with that uncertainty. And it doesn't make people good. It doesn't make people bad. It just means that this is a really complicated thing. And we just have to try to figure out the best ways to talk about it to the public so people can understand both the uncertainty and why our things are changing. And I don't think we've done a great job in that. Like why were masks bad at the beginning and now good? What, did I misspeak there? Did I make a mistake? I think it's hard for people to acknowledge when they make mistakes or when evidence have changed. And I think it's been a really complicated disease. And hopefully we will learn from this for the next pandemic, because there will probably be again sometime in our lifetime. And hopefully we can learn from this what we did well and what we didn't well, and how we hurt people and how we help people, and the way we communicated and help people make decisions about their health behaviors.
Right. Absolutely. I was interviewed on TV many times, and I felt like I was always saying the same thing. So there were some announcers, one in particular, who would say, but the numbers are rising. And I would say, wait, yes, many people are verified that they have their carriers, they have the virus. It doesn't necessarily mean they have it very strongly. They could be asymptomatic. Some of them are defined as severe patients. That only means saturation level from a certain degree. And if they're age 55 and above and their saturation level is, say, 94, then they're a severe patient, but they are home and then will not be hospitalized. So let's parse this to people who have COVID-19, people who are severe patients but at home, people who are ventilated, people who are dead. Thankfully, very fewer as you go along with the numbers. And it's a complicated message, and our minds are not wired for complicated messages. And TV loves big headlines, right? They don't love saying, well, this is complicated, because that just, who wants to buy that newspaper? So it's on us to try and understand what is really happening, what we're really hearing, and what's good for us and what's healthy for us. And, that's, I think, what everyone wants is for themselves and their families to be healthy as first and foremost.
And we all have different, and I know you have another question, so I'll end this, but I think also we all have our risk assessments and we have different risks, right?
Yeah.
Like my kids are we're not even fully vaccinated in my family, right? Because of the ages, which is very different than my friend whose kid has been vaccinated for 6 months. Like the choices we make are also based on our health and the health of the people that we're living with, and our risk assessment and how much risk we're willing to take one way or the other.
Exactly. And we have to learn to respect that. I think that was a massive lesson as well.
Yes.
Well, I really appreciate both of your very thoughtful and nuanced answers to that
Very
question,
long.
because it is such a complicated issue. And, like people have hesitancies for all kinds of different reasons. Like it's not just one thing. So I really appreciate that you considered that as the whole big picture of that. Let's see. I guess just in the last few minutes that we have here, I'd love to know, Talya, what do you hope that readers take away from your book?
I think two things. The first is just an acknowledgement that dealing with medical decisions is hard. It's empowering, but it's also hard. Really, for everybody. It does not reflect poorly on who they are if they're finding it hard. It just means they're human. That's the first takeaway, and you're getting it for free. And the other is really to acquire tools for how to make better decisions, and at least to understand what they need in the context of medical decision making, from their relationship with their doctor to how they receive information and how they receive numbers and what sort of digital health they seek and what they can hope to get from it, all of the above. So I hope that they're really empowered, because I think to tell someone, here you go, make a choice, that's not empowering. That in fact can be abandonment, just that looks like empowering. It's like, no, I can't, I can't fly a helicopter. It will not empower me. If you make me sit in one, I will just feel incompetent. And that's not how people deserve to feel. They deserve to have the tools and the skills to make their choices.
Yeah, thank you. Thank you so much. Are there any closing thoughts that either of you would like to leave our audience with before we say goodbye?
I'll leave that to Dr. Miron-Shatz. I just know I've really enjoyed this last hour and learning more about your book and your thoughts. But I'll let you have the last word today.
I want to say thank you. My last words are words of thank you to the wonderful people of Well-Read Books, and to Salem, who put this together, to Dr. Angie Fagerlin, who you're really a wonderful conversation partner. I think because of your personality and because of your vast experience in medical decision making and the way you really care about it, it comes across, and it's meaningful. And it's important for me that people will know that we don't just study this stuff and write books. And here I am promoting my book shamelessly. Yet once again, we actually really care about this. We really care about how people make medical choices in their health and how they feel, both physically and emotionally. So these are my closing thoughts. I want to wish everyone in Salt Lake City and everywhere a wonderful rest of their day.
Hey, yeah, thank you. And I think it does come through in this conversation how much you both really care about this. And I'll be leaving links where you can get Your Life Depends on It as well. But thank you so much for this lovely conversation. I hope that you two have a lovely day as well.
Thank you. Goodbye.